Extract 2. Questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase.
Hello, you were referred by your GP for a problem with your skin, is that correct?
Yes, that is correct. I told him it was nothing, but he insisted I came to see you, so that's why I made the appointment.
Well, let's see what we have here. Your file says that you have thickened, heavily lined skin on the back of your neck. Do you know how long you have had this problem? Have you noticed any changes recently?
No changes, and I've no idea about how long. I mean, I've worked in the sun my whole life, so who knows when it started.
Do you work outside, Mrs. Patch?
Oh yeah, I work on a farm, and I also like to fish, and in general spend a lot of time outside doing all sorts of activities.
So I can see there is abundant evidence of sun damage on the back of your neck, as well as areas of your cheeks and ears. There is weathering and solar litiginosis, or liver spots, along with several areas of solar keratoses on your hands, which is the rough, patchy skin. The skin on your arms and trunk appears normal.
Yeah, I generally wear long sleeve shirts, so my arms are protected. I also usually wear a hat when I am working, but I guess it doesn't really protect the back of my neck.
That's good about wearing a long sleeve shirt, but you need to be careful with the back of your neck. For example, you could wear a bandana. The condition you have is called cutis rhomboidalis nuchae, which is a thickening and weathering of the epidermis, as well as solar elastosis of the underlying dermis. The collagen in your neck has been damaged, as well as the elastic skin.
Is that serious? I mean, it sounds serious.
Well, it is quite common, especially in people who spend a lot of time outside in the sun. In fact, the condition is commonly called farmer's skin or sailor's skin. The good news is that it has no malignant potential, but the bad news is that it does indicate that you are a higher risk for the development of skin cancers caused by sun exposure, such as basal cell carcinoma and melanoma.
Any recommendations going forward?
Because of your increased risk for skin cancer, I recommend that you have yearly skin checks by a qualified dermatology provider.
I can't just put sunscreen on and call it a day? I mean, you said it is not malignant, right?
No, not exactly. Application of sunscreen will prevent worsening of the skin on your neck, and in general, I advise you to protect yourself from the sun, particularly areas with a lot of damage, such as your neck. However, this will not undo the damage that has already been done to your skin during the last several decades. As with any type of cancer, early detection of skin cancer will greatly improve the prognosis and effectiveness of treatment. Skin cancer is more common than many people realize. In fact, 1 out of every 3 cancers diagnosed is a skin cancer. And Australia is the country with the second highest incidence of skin cancer in the world.
Yeah, I see your point. So I need to get a bandana, some sunscreen, and make an appointment with
Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello. So today, it's a routine appointment. So, how is everything going, Mr.
Not so great.
I'm sorry to hear that. Are you having problems with your stage 5 chronic kidney disease? You were diagnosed 2 years ago, is that correct?
Yeah, that's right. I'm being seen at the Advanced Chronic Kidney Disease Clinic for my renal problems. I recently decided to have hemodialysis. In general, things are going okay with that.
Okay. What about your asthma? Have you experienced any difficulty breathing lately?
No, nothing like that.
So tell me, how are you feeling?
I've been feeling very tired recently, to the point of weariness.
Okay. Any problems with your memory?
No, not that I can think of. The tiredness mostly affects my social life. I just can't bring myself to go to my chess group or go walking with a few neighbours. Also, I have been avoiding everyday activities I used to enjoy, like having a meal with my family.
Mr. Kelly, during the last month, have you often been bothered by feeling down, depressed or hopeless?
Yeah, I would have to say yes. I feel that way frequently.
How long would you say that you have felt bothered?
To be completely honest, ever since I was a teenager. Looking back on it now, my teenage years were filled with frequent periods of emotional abuse. It also sometimes became physical. I often just didn't feel good enough and struggled with trying to fit in with the social groups at school. I often feel very isolated.
I'm sorry to hear that, Mr. Kelly. Based on what you've told me, I'm going to give you some information about depression. Also, I know that the Advanced Chronic Kidney Disease Clinic, where you're being treated, has a psychology department attached. I'm going to refer you to that department for a full psychological assessment.
Okay.
Do you have any questions about depression or possible treatment options?
I don't know. I've thought for a long time I needed to see someone, but I just didn't know how to get started.
I understand. It can feel like a big first step. Depending on your assessment, the psychologist will suggest a treatment plan. In the case that it is depression, the treatment plan will likely include cognitive behavioural therapy. This would help you to counter your negative thoughts about yourself.
Would I have to take medication?
You might. We'd have to look at any likely side effects that taking an antidepressant would have, as well as any potential interactions with your existing medication. I want you to know that I'm not just handing you off to the psychologist and backing away. I will be in communication with your team at the kidney clinic throughout this process, and I will follow up with you once the assessment has taken place to go over the proposed treatment plan. Then we will have regular follow-up appointments to monitor the progress of treatment and the side effects of any medications that are prescribed.
Thanks. That means a lot.
Now, is there anything else?
Part B. In this part of the test, you will hear 6 different extracts. In each extract, you will hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio.
Now look at question 25. You hear an A&E doctor briefing a colleague about a patient. Now read the question.
Mrs. Mason, a 32-year-old woman, came into the A&E last night for a mildly itchy rash on both legs that had been ongoing for 3 days, as well as lower extremity joint pain and abdominal pain. She informed me that she has had a winter cold for about 1 week and has been taking over-the-counter cough medication for her symptoms. She told me that she suspected that the rash may be the result of an allergic reaction to the cough medication, but that the rash worsened after she stopped taking the medication. She said she has not had fever, diarrhea, vomiting or other symptoms. Lab results and a chest radiography are normal. I'm going to call for a dermatology consult.
Question 26. You hear a dermatologist in a training session with an intern. Now read the question.
So, Sarah, what do you know about your patient?
Patient is a 67-year-old man presenting with 2 nodules on his left elbow. He has no history of skin conditions, but was diagnosed 2 years ago with rheumatoid arthritis, which he manages with non-steroidal anti-inflammatory drugs. The nodules are uncomfortable and aesthetically displeasing, but they're not causing the patient any pain.
What do you recommend as the next step?
During my examination, I noticed 2 large, firm, skin-coloured, subcutaneous nodules. I recommend performing a biopsy to check for rheumatoid nodules.
What is the cause of rheumatoid nodules?
Rheumatoid nodules are
Question 27. You hear an intern asking a senior doctor about the diagnosis of a patient. Now read the question.
Dr. Norris, I have a question about the patient with the long-term ongoing tremor. Shouldn't we be considering Parkinson's disease as a possible diagnosis?
Yes, it is a consideration, but there are a few symptoms you should look closely at to differentiate between the 2 diagnoses. For example, the patient has been experiencing a hand tremor for quite a while, but he also has a head tremor. Also, the overall health of the patient is good. Patients with Parkinson's disease often have other problems. Do you know what those are?
Oh yes, stooped posture, slow movement, memory loss. Thank you for helping me to look more closely at the symptoms.
Question 28. You hear a morning briefing in a ward. Now read the question.
Now we come to Mr. Jenkins, who came into the psychiatry A&E department last night. Cheryl, can you present the case, please?
Of course, Dr. Scott. The patient is a 40-year-old man who presented with inappropriate behaviour and confusion. According to his records, he has appeared fidgety for several years. A neuroconsult found him to be alert, but easily distracted. He also had problems spelling world backwards, but demonstrated no short-term memory problems. With ambulation, jerky movements are present in the hand and his balance is altered. A urine drug screen came back negative.
There seems to be a lot we don't know about the patient. Cheryl, please get a full medical history on this man as well as his family. Then, depending on what we find out, we can move on to tests. Now.
Question 29. You hear two radiologists discussing the possible diagnosis of a patient. Now read the question.
I have a case of a 53-year-old female complaining of a sore throat, difficulty swallowing, and the sensation of a lump underneath her tongue. She was referred to me by her GP, as it appears that the symptoms have been worsening over the past few months. I ordered a CT, as plain radiographs showed nothing.
Let's take a look at the scans. Oh, that's interesting. Do you see that? There appears to be a bony outgrowth arising from the base of the temporal bone of the skull.
That could definitely be the cause of the symptoms of this patient. Have you ever seen a case of Eagle syndrome?
I think when I was an intern.
Question 30. You hear a patient expressing a concern to an occupational therapist. Now read the question.
So today we're going to conduct an occupational therapy assessment to see what your needs are. I can see that you have progressed to fully weight-bearing and that you are using a walking stick.
Yes, it has been a long journey since my accident. I have started to use the stairs by relying on one handrail and my walking stick.
What are your main concerns now, Sheila?
I really want to be able to get into a bath to shower. I have tried, but stepping into the shower is very painful. Also, I'm not able to use my right arm to reach out and support myself when getting into the bath. pain in my leg and the problem with my right arm makes me nervous about showering.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36.
Hello everyone. Thank you for having me here. I'm going to talk about a current hot topic in the field of gastroenterology and nutrition using a low FODMAP diet to treat irritable bowel syndrome or IBS. IBS is a fairly common condition in Australia. According to the latest numbers, IBS develops in as many as 1 in 5 Australians or 20% of the population at some point in their lifetime. Looking outside of Australia, about 15% of the global population, or 1 in 7 people worldwide, struggle with IBS. An interesting fact is that women are twice as likely to develop IBS as men. A bit of background on IBS before moving into the main topic of the day. IBS is a symptom-based gastrointestinal disorder for which there are no diagnostic tests. Instead, IBS is diagnosed after ruling out other digestive conditions such as Crohn's disease and celiac disease. IBS is characterized by irregularities in bowel habits such as diarrhea, constipation, or a combination of the two. The contradictory nature of symptoms, as well as their tendency to change over time, makes this a very difficult disease to manage. While the cause of IBS is still unknown, its development and flare-ups are thought to result from problems in the interaction between the gut, brain and nervous system. Many people who develop IBS do so during or after particularly stressful life events and experience flare-ups in the presence of strong emotions. IBS is unpredictable, making it difficult to manage for healthcare providers and their patients. This unpredictability, combined with the nature of the symptoms, means that IBS has the potential to interfere with many aspects of patients' lives, and if left untreated, It can lead to unintentional weight loss, nutrient deficiencies, and depression. Treatment for IBS can include medication such as antidiarrheal medicines, painkillers, constipation treatments, antispasmodics to treat the symptoms of the disease. But they don't get at the potential underlying causes of the problem. Another part of the treatment plan for IBS is a change in diet and lifestyle. This is where the low FODMAP diets come in. As previously mentioned, IBS is an unpredictable disease and presents differently in each patient, so a FODMAP diet may not be appropriate for all patients. Now, let's get into what the low FODMAP diet is all about. FODMAP stands for fermentable oligo, di, and monosaccharides and polyols, and excludes popular and flavorful ingredients like onions and garlic, which can make sticking to a low FODMAP diet quite challenging for patients. This is where registered dietitians come in, as it is part of our job to make the low FODMAP diet sustainable for patients. We will get back to this later. Next, I want to give you a bit more information about the diet itself. The diet begins with an elimination period in which FODMAP-containing foods are limited. FODMAPs are short-chain carbohydrates, including lactose, fructose, fructans, fructans, and galactans, found in some grains, fruit, vegetable, legumes, and dairy products, and are difficult for some people to digest and absorb. In addition to garlic and onion, other FODMAP-containing foods are artichoke, asparagus, celery, kidney beans, pickled vegetables, cherries, pears, and cashews. What happens is when FODMAPs reach the small intestine, they move slowly, attracting water, and then as they pass to the large intestine, FODMAPs are fermented by gut bacteria, producing excess gas. The extra water and gas causes the intestines to stretch the gut, which is particularly painful for people suffering from IBS, as they already have a highly sensitive gut. After an elimination period of 4 to 6 weeks, foods are gradually reintroduced to determine which foods trigger IBS symptoms. Once a patient's trigger foods have been identified, a dietitian can support the patient in developing a well-balanced eating plan whose objective is to manage future IBS symptoms. Research has shown a low FODMAP diet to be helpful for improving bloating, abdominal pain, and flatulence among individuals with IBS. As I mentioned earlier, it won't work for all IBS patients, but it is certainly worth a try for those patients who haven't had success with other dietary changes. As you can imagine, following a low FODMAP diet, even for a short period of time, can be challenging, especially for patients who don't have the ability or time to cook their own meals from scratch. Fortunately, more and more companies have started to offer low FODMAP products that help people to follow the diet more easily.
Now look at Extract 2. Questions 37 to 42.
Hello, welcome everyone, fellow dermatologists and interested health professionals. I want to start off by thanking all of you for taking the time to attend this session. I'm honoured by your presence and I genuinely hope you walk away from it energised and armed with information to take action. As we all know so well, dermatologists are currently facing a series of unprecedented challenges that pose a real threat to patient access to high-quality dermatologic care due to the mounting difficulties facing those of us in private practice. More and more of our patients are being forced to pay out of pocket to seek out our services, which limits their ability to continue to see a dermatologist and to receive appropriate medical treatment and advice for their skin conditions. But even bigger challenges loom ahead for our speciality. We must all ask ourselves how dermatology will fit into the big picture as national healthcare priorities focus on large-scale public health issues such as hypertension, diabetes, obesity and depression. In this crowded field of overwhelming public health crises, we must make the case for dermatology. For example, we dermatologists play a critical role in reducing the burden of skin cancer, a cancer that will affect approximately 2 in 3 Australians before the age of 70, and that is the third most common cancer in the country. Research also shows that we often serve as a gateway for women's health. A recent survey reported that 88% of dermatologists have discovered internal disease in female patients through examinations of patients' hair, skin, nails and mucous membranes. But the unfortunate fact is that most policymakers do not really understand the critical services we provide. Furthermore, policymakers often don't even take our speciality into consideration because there are so few of us. In fact, fewer than 2% of doctors specialize in dermatology. That is why my first proposal is to work to increase the number of residency positions available to train new dermatologists. There are currently approximately 300 residency positions per year, a number which has remained fairly constant over the last decade, while at the same time the number of people in the country has grown quite rapidly. In order to increase the number of residency positions, we need to find a funding mechanism to financially support them. A related proposal is to increase the number of women in the dermatology workforce. As you've probably noticed, women make up an increasing percentage of medical students. For this reason, we need to focus on attracting women to the field of dermatology. This leads me to my second proposal, which is to work on correcting the perception of dermatology both in the medical community and outside of it. Dermatology has become a much more diverse speciality over the years. As I mentioned earlier, policymakers generally don't have a thorough understanding of the work that dermatologists do. They still see us as the wart and acne doctors of the past, or just expensive cosmeticians. We need to work to make the public and policymakers understand that issues like acne and rosacea are medical issues, so they will seek out appropriate medical treatment with a qualified dermatologist instead of turning to familiar drugstore products such as baby oil or coconut oil. A result of the shortage of dermatologists caused in part by the reasons detailed above is that more and more physicians without specialty training are starting to practice dermatology. You often see doctors opening so-called skin disease treatment centres. Skin disease treatment centres to attract patients who are on long waiting lists to see their dermatologist. Having individuals treated by physicians without specialty training is not good for anyone involved, particularly the patients. We need to demonstrate to our fellow physicians that we are to be valued and recognised as key players on the local patient care team. One concrete way that we can help to correct the perception of our speciality is through getting more involved with research. When dermatologists turn away from research, it is pharmaceutical companies that step in to fill the void. Also, when we do choose to do research, We need to be careful about the funding source to make sure we are not doing the work of the previously mentioned pharmaceutical industry. The issue of industry-funded research is one that I will not get into at this time, but it is definitely worth more exploration. That is the end of Part C. You now have 2 minutes to check your answers.